Good morning. I'm thrilled that you're all here and looking forward to a good conversation. You can feel free to interrupt me with questions. And I might say, I'm about to cover that. or we can get into some discussion. So I want to start by telling you a story. And I'm thinking about this because I know there's some people in the room who I could invite to tell the story rather than me and who know it better than I do. But that will eat into my time, so I won't do that. So imagine a community. It could be your own community. It could be not your own community. But a small, tight-knit community. Could be geographic definition of community, or it could be a racial ethnic definition, could be a community defined by interest, but regardless, the story looks kind of the same. So a woman who is a part of that community becomes ill and eventually finds her way to a healthcare provider and goes through a number of tests and things and is told, you have breast cancer. Not only is she told that, but she's told, and the breast cancer has spread beyond the breast and is in other organs of your body. So we can give you medications to help prolong your life and to help reduce your suffering, but it's not curable. The woman, of course, is devastated. Her family is devastated. Her community, as they find out what has happened and what is happening to this woman, is devastated. As a woman who's like a core of the community, a connector in the community, somebody who's like knows every child's name in the community and can call their parent and say, do you know what your child was doing? She's a member of her church, and she's like the lifeblood of some committees in her church. And all of you in this room, I think, know how some of this story goes. Eventually, the woman dies of breast cancer. And really, the community has suffered a great loss. And they're devastated. And they say, we don't want this to happen to anybody else in our community. How did this happen? And what can we do to make sure it never happens again? So they get some help from some other communities, maybe from some experts who say, well, your community is not undergoing breast cancer screening at the rates they should be. So you could help bring those rates up. So the community develops a screening program, and they go out and they find whatever method works best in their community to get women to go in for breast cancer screening. Unfortunately, there's still more women in that community who die of breast cancer. Doesn't really turn things around. And I want to explain to you why we think that's the case. So you don't have to know much about breast cancer to understand this picture. There are breast cancer, there it is, okay. Breast cancer has different stages. Stage 4 is actually, stage 0 is actually not yet cancer. And stage 4 is cancer spread throughout your body. It's really all you need to know to understand this. And we used to think that every breast cancer had to go through each one of these stages before it got here. So every breast cancer, we used to think, was a stage 0 cancer before it was a stage 1 cancer, before it was a stage 2 cancer, etc. And in this context, breast cancer screening makes a whole lot of sense. So with that thinking, mammography was developed, mammography was tested, it was shown to be effective in decreasing breast cancer mortality. in certain populations. And we came up with this public health message, which I'm sure many of you have heard. Many of you, including myself, have probably said. Okay. And that public health message led to some assumptions and some beliefs that we're now being forced to re-examine. So some of these assumptions and beliefs we still think are true, and some we're not so sure are true, or we're pretty sure they're not true now. So this first statement, women whose cancers are detected at a lower stage do better than women whose cancers are detected at a later stage. That statement still holds true as far as we know. So if you are diagnosed with breast cancer, and at the time you're diagnosed, you're stage 1, you are going to do better than if you are stage 4 at the time you're diagnosed. And that's been borne out by a whole lot of research and life experiences. This next statement seems to follow from it, but is not as true. So a woman who's diagnosed at a later or more advanced stage, our assumption is, oops, that's a mistake. She could have been diagnosed at an earlier stage if only she had screening, if only everything, all the stars had aligned right, she could have been diagnosed at a stage 1. And it makes total sense, doesn't it? If you find something, I mean, we kind of know in public health, intervening early is a good thing. If you wait until a disease has progressed, then you're not as likely to have a good outcome. And we all make the assumption that we could have intervened for that earlier outcome. But that's not really the case, and I'm going to try and convince you of that. So, back in my mother's generation, my grandmother's generation, when you're talking about breast cancer, there were really 2 groups of women. There was most women in the world did not have breast cancer, and there was a much smaller group of women who had breast cancer, most of which they had found themselves. When we started screening on a regular routine basis, so in like the mid-1980s, we could really divide women, the women with breast cancer, into 2 different groups. Whoops. We have women who have early stage breast cancer that was maybe detected on mammogram, and women with late stage breast cancer. And our public health messages were basically these women with late stage breast cancer could have been women with early stage breast cancer if only they'd been going through screening. So here's what we expected to happen with breast cancer screening. We expected that this group of women without breast cancer would stay the same size. We expected that this group, the group of women with low stage or early stage breast cancer, would grow bigger, because we expected that we would have fewer of these women with late stage breast cancer, and instead we would diagnose them early and move them into this group. So, here's what actually happened. It is absolutely the case that we got more women with low stage or early stage breast cancer. The surprise, the unfortunate and unhappy surprise, is that it didn't come from this group. This group stayed exactly the same in number. So these more early stage breast cancers were not coming from the late stage group. They were coming from the women who didn't have breast cancer group. That's not what we intended to do at all. Some of you may say, no, that's not what happened. Here are the numbers. This graph goes from 1976 up to 2002, and I could draw it up to 2012, and it would look essentially the same. And these are, in trouble with this arrow. There it is. Okay, this is number of women, and these are 3 different curves. This is the number of women with local stage, early stage breast cancer. And see, it went up, just like we expected. This is the women with regional stage, so that's stage 2, stage 3 cancers, still confined to the chest area, but beyond just a single tumor. And these are the women with stage 4 breast cancer. And you can see that this line is about as straight as any line you can draw in looking at a population. It has not budged. Now some of you may say, well, yeah, but not every woman gets screened. If every woman got screened, we would see different numbers. Actually, a lot of women get screened. So the latest statistics, and actually this are that nationwide, about 75% of women age 50 and older get screened every other year. In California, it's 80 to 85%. That's about as much compliance as you can get in anything in public health. And here's another piece of evidence. So this is comparing 2 different cancers. One with a screening test that works, and one, I'd posit, with a screening test that does not work. So this is cervical cancer. And this is what has happened to cervical cancer as we've had early detection of cervical cancer. This is the rate of disease. So numbers of cases of cervical cancer have plummeted, gone down to almost a third of what they used to be. And this is cervical cancer death, also decreasing to about a third of what it used to be. This graph of breast cancer doesn't really look the same, does it? Now, there's been some reductions in death here, and the kind of party line, the thing I see in almost every paper or newspaper article or magazine article is death rates for breast cancer have decreased due to early screening and treatment. I would suggest to you that actually this is just treatment. It's not from early screening, because we have not seen at all a shift from late stage cancers to early stage cancers. So it all made sense that that's what we should see, and certainly that's what we've seen in cervical cancer here. So why have we not seen this shift? Yes?
Are you doing an age here? I mean, did you start younger, or is it always from 50 on?
So the
Screening.
statistic I gave you about screening rates was 50 on.
50 on, so from 50 on it's increasing.
No. The age I gave you about how many women get a mammogram was talking about 50 and over.
Okay.
These curves are all cases of breast cancer. So this includes everybody. Okay? The reason I use age of 50 and every other year is because that is the U.S. Preventive Health Task Force recommendation. So it's a little unfair, I think, to ask a 42-year-old woman, have you gotten screened or not? and start counting that as compliance with screening, because the 42-year-old woman who has not gotten screened may have not gotten screened because she's following the new guidelines, or may not have gotten screened because she doesn't know she should get screened. And you can't tell the difference between those. Whereas everyone agrees that women over 50 should get screened, so it's a better denominator to ask. Okay, so we're beginning to see some, to have some clues about what might be going on. So I want to be very clear, this is a hypothetical picture. This is not anything and from any study that anybody's done, but it matches a lot of our observations in breast cancer science. So this is a picture, I keep hitting the wrong button. Okay, this is a picture of 4 hypothetical women with 4 different tumors. And let me explain a bit about this graph. So this bottom bar is tumors that are tiny. And the only way you can tell there's a tumor there is if you look at it under a microscope. So you would have to have accidentally done a biopsy in the right place to actually see that, or see it on autopsy or something. This bar is tumors that have grown to the point where they can be seen on a mammogram or other detection method, but they're still in the breast itself. This third bar is cancers that have spread out of they're beyond a single tumor in the breast, but they're still in the chest area. And this top bar is tumors that have spread throughout the body. So again, hypothetical here. There's tumor A, woman A with tumor A. This tumor starts, oh, one more thing. These little arrows are every 2 years, a mammogram. So that's a screening. So this woman has a mammogram every other year and has a tumor that is growing slowly, but it never reaches this second bar. So it's never seen on a mammogram. The woman doesn't know she has a tumor. The healthcare provider doesn't know she has a tumor. It's there, but none of us know about it. And then she reaches 110 and has a heart attack one night and doesn't wake up to 111. So she's had a long, happy life, never knowing she had breast cancer. This woman has not had such a fortunate life. She also has a slow-growing, but less slow-growing tumor. So she goes along, she has 1, 2, 3, 4 mammograms that are all shown clear. And then on her 5th mammogram, she is told, oh, you have a suspicious lesion there. She gets a biopsy and she's told, you have breast cancer. What this line indicates is if this woman were not treated for that breast cancer, she also would have continued going on to die at 111 of a heart attack. But instead, she has her tumor removed here, and she gets surgery and radiation and chemotherapy when she didn't need it. She was going to live her full happy life without any of that treatment. This tumor represents what we thought we were doing with all breast cancers. So this woman goes along, she gets told she has a breast cancer at this screening, and if her breast cancer were not treated at that point, then it would have continued growing, it would have spread regionally, and eventually it would have spread throughout her body and led to her premature death. this is the scenario that we think we're doing with breast cancer screening followed by treatment, is catch it when it's early, prevent it from becoming a cancer that spreads throughout our body. And then this highly unfortunate woman, these are the tragic cases we hear about over and over again, where a woman has a mammogram, she's told everything looks fine, and before she has a chance to have a second mammogram, she has a tumor that has already spread throughout her entire body. So in these 4 hypothetical cases, screening did not help woman A, screening did not help woman B, screening did not help woman D. Screening only helped woman C. As we understand more and more about the molecular genetics of tumors and learn how to analyze tumors better, we're beginning to understand that indeed there are different types of breast cancers marked by different molecular subtypes that behave differently. And that this is probably more of what is going on in breast cancer and why we have not seen the effect we expected to see with screening. This is a kind of a complicated graph, so I'll walk you through it. And it is, so this is, there are many such diagrams, and you can argue about the specific numbers in these diagrams, and there are people who spend their careers arguing about the specific numbers in these diagrams. But I don't think anyone disagrees with the basic concept. This is becoming pretty generally accepted now. So here we have 1,000 women who are over 50. And we put them through breast cancer. Well, we put in these 2 scenarios, we either do put them through screening or we don't. So this bar is what happens to those 1,000 women who are not screened. And the second bar is what happens if they are screened. So some women are diagnosed with breast cancer and die whether they were diagnosed through screening or through not screening. And so this number just die regardless. The difference in deaths is 5 women out of these 1,000. So you have saved, by screening, you have saved these 5 lives. And that's a great thing. Those 5 women are very grateful. Their families are very grateful. Their communities are very grateful. It's a great thing. A lot of these women, so all of these women in pink, would have done fine whether they got screened or not. So, or rather, this bar are the women who do fine even though they're diagnosed with breast cancer, even though they got diagnosed because they found it themselves and not through screening. This is what we're now living with in the downside of screening. These 17 women are those women who would have never known they had breast cancer if they hadn't been screened. So they would have lived to 110, not woken up at 111. But when we do screening, we end up treating those women, those 17 women, with surgery, radiation, a year of chemotherapy, 5 years of tamoxifen, when it had no effect on their lives at all, except for making them go through that year of treatment or 5 years of treatment. So that's 5 lives versus 5 lives saved versus 17 really, really negatively impacted, I find that a very difficult balance to judge myself. And I don't think I should judge it myself. So what I would suggest to you is the message we ought to be telling women about screening is it has its upsides, it has its downsides, and you should decide whether for you, you should undergo screening or not. Now, some public health advocates say, oh, that's much too complicated a message. Women can't understand this complexity. I would answer back, women are much better at dealing with complexity than men are. We deal with it all the time. We're our primary family caregivers. We all work. We work in our community. We are multitasking all the time. We make very complex decisions all the time. And this is just one more that I'm suggesting a woman make. Instead of us saying, oh, you should have been screened. And if you'd gotten screened, you wouldn't have metastatic breast cancer. So, that's one of the ways in which the paradigm is shifting around breast cancer, is we're beginning to understand its many different pathological processes that are happening, and they do not all behave the same. And screening is not having the amazing, powerful impact we thought it was going to have. There are other things about breast cancer, just a second, that are puzzles that we need to figure out. But first, I'd like to hear your question or comment.
Yeah, so are you saying that when they do the screening and they see that there's a small tumor, can't they do a biopsy to see whether or not it's going to be a fast-moving tumor or not? Or they just have to assume it's going to be fast-moving and they get rid of it no matter what?
What medicine has done until very recently is assume that everybody's in that worst case. It's kind of what doctors are raised to do. Hope for the best, but treat as if it's the worst. Because you want to prevent things from happening. So, unfortunately, what we've seen is even with ductal carcinoma in situ, which is a disease that has really been created by mammograms. Explain that in a minute. It's not a cancer yet. It's considered a precancerous lesion. And we know that somewhere in the neighborhood of 30% of women who have ductal carcinoma in situ will go on to develop breast cancer, but 70% won't. But we can't tell them apart, so we treat them all. So the fashion in breast cancer treatment has been, until recently, for women with ductal carcinoma in situ, to treat them as if they have breast cancer. Do surgery, and often ductal carcinoma in situ is in multiple places in a breast, so lumpectomy becomes not the option. So there are women out there having double mastectomies because they have a precancerous lesion, and then having radiation, and then having chemotherapy, and they don't have cancer. So, quick answer is, you're right, we can't tell the difference, even on biopsy. Can't tell the difference by looking at it. And that's still, there are studies underway to try to test different possible markers or predictors for ductal carcinoma in situ. And there are now available clinical markers for actual breast cancers that can help in that decision about, does this tumor need chemotherapy or does it not? And those are now standard practice. So we can make And there they do very much give the decision to the woman. Okay, here's what we think. We could put you in a low risk group or a high risk group or a medium risk, and now you decide, do you want chemotherapy? Does that answer your question? Okay. So these are 2 maps of California. I hope you recognize that part. In this map, we're showing the incidence of breast cancer. So how many women per 100,000 women in that county get breast cancer each year. And it ranges from the pale yellow color to the deep red color, from a rate of basically 100 per 100,000 to a rate of 150 per 100,000. That is a big variation. That's a 50% variation in breast cancer rates in one state. Kind of remarkable. So I have, when I've done this in other places, I've been able to circle one county. The Bay Area, I can't do that. So I've very nicely for you pointed out the Bay Area. So you can see that there is variation statewide. So there are some counties that have very low rates of breast cancer, and other counties right next door that have very high rates of breast cancer. We don't know why. These are interesting questions. This map is deaths from breast cancer. So this is the mortality rate from breast cancer. And you can see, for example, let me give this county a little highlight here. Low rate of breast cancer, but high death rate from breast cancer. Just in this picture, there are so many research questions and things we do not understand about breast cancer that we can't explain. Here's some, this graph has some other questions that we don't really understand, some of which we've known for a long time and actually spent a lot of time trying to do research around, and we still don't understand them. So these are, again, rates of breast cancer per 100,000 women in these bluish, light blue bars. And in the orange bars are deaths from breast cancer. And these different groups are different racial ethnic groups. So this is Caucasian women, non-Hispanic Caucasian women. They have the highest rate of breast cancer. This is African American women. They have a lower rate until very recently. And unfortunately, the most recent statistics and a very recent paper that was just came out last month showed that African American women are now catching up to white women. This is not a case where we wanted African American women to catch up with us. And this is not getting any better. So you notice the death rate from breast cancer is higher for African American women than it is for Caucasian women or any other woman. And there's been a lot of research around this issue, and we still don't understand it. The one thing that is pretty clear is it's not about screening. So again, I was talking about screening rates across the country and certainly in California. Both nationally and specifically in California, African American women's screening rates are higher than white women's screening rates. So the higher death rate, the higher death rate is not because they're not getting screened. So now what do? We thought we had this great tool, and many of us, me, many of you, have been involved in trying to make sure that this great tool is is available to everybody and is used by everybody. And now I figured out, it's not a great tool. So where do we go from here? I would suggest what we need to do is figure out not how do we detect breast cancer better, but how do we prevent it? And there are those who say, well, okay, but we have to figure out the causes first, because if you don't know the causes, you can't prevent it. I would answer back, in the history of medicine, we have cured many diseases before we knew what caused them. In fact, sometimes it is figuring out how to prevent them that taught us what the cause was. Infant mortality, actually maternal mortality, was a huge problem long before we knew about germs. And we learned that surgeons and obstetricians washing their hands between patients decreased maternal mortality remarkably before we understood why that was the case. It's just, I mean, there are many other examples, but we don't necessarily have to know the causes before we can learn to prevent a disease. This slide is included just from the National Cancer Institute. It just says the cause of many cancers remains unknown, and that's largely true with breast cancer. So I want to pause for a minute and make a distinction between causes and risk factors, because many of you have probably heard about risk factors for breast cancer and wondered, well, isn't that a cause? And what I'm going to tell you is no. They're related, but they're very distinct. So cause is something that if you have the thing, you get the disease. If you don't have the thing, you don't get the disease. That's pretty clear, and I think you all probably understand that concept. Risk is a factor that only applies to groups of people. So you cannot talk about you should not talk about individual risk factors. A risk factor, the way a risk factor is defined is you have two groups of people, and one group has that factor, the other group does not have that factor, and the disease happens more often in this group that has the factor than it happens in the group that does not have the factor. But it doesn't mean that all the people who have the factor have the disease. And it does not mean that none of the people who have the factor have the disease. It's a small difference between two groups of people. And it's really the only way it should be understood and talked about. So an individual woman in either one of those groups still is at risk of the disease, so can get the disease. It just happens a little bit more often in the group that has the risk factor, that has that factor, than in the group that does not have the factor. It can give us clues about cause. Sometimes it might be a cause that we just don't fully understand in order to define it well enough to have an all or nothing scenario. Sometimes it's things that travel along with causes. And I'll illustrate that. So this is the list of commonly cited risk factors for breast cancer. There are a few that we can't do much about. Everyone in this room is female. So if we had a room next door that was all men, more people in this room would end up getting breast cancer than people in that room. But again, it's not a cause, it's not a direct one-to-one correlation. there are men with breast cancer, and there are women without breast cancer. Older age, so we're all aging as we sit in this room. Can't do anything about that. This next one, high socioeconomic status. Now, it's been observed for decades, maybe even a century now. We don't know why. And it's hard to come up with okay, how does higher socioeconomic status have a direct link to breast cancer? We don't think it's the green dye in money that causes breast cancer. Because low socioeconomic women still get breast cancer, just not at higher rate. There are others that are even more confusing, like obesity. Obesity is actually a protective factor for premenopausal breast cancer and a risk factor for postmenopausal breast cancer. So if I were being a really good public health person, I'd be telling you, okay, I'll be really skinny. No, sorry, I'll be fat when it's hard to be fat when you're young. And then once you hit menopause, make sure that you lose a whole lot of weight.
And it's so much harder to do it when you're postmenopausal.
Yeah, yeah. Another important fact about risk factors and breast cancer is that only 30 to 40% of women with breast cancer actually have any of those risk factors besides being a woman and getting older. So again, the group that does not have the factor still gets the disease, just at a lower rate. So this is a large group of women who don't have those factors, who still get the disease. Okay. Now, there have been a lot of studies of breast cancer causes, and there have been some summary papers, and a very important summary paper was written in the 80s by some world-renowned epidemiologists. Said, okay, we're going to take all the information we know about breast cancer and its causes, and we're going to classify those and try to determine kind of where those factors lie, and what we can say about, is breast cancer caused by genetics? Is it caused by lifestyle? Is it caused by your occupation? Is it caused by pollution and environmental contaminants? And so their names are Dahl and Pito, and this paper has been cited millions of times since then. It's one of those hallmarks of papers, of cancer papers that everybody cites. And it has really shaped scientists' thinking and like, okay, well, Dahl and Pito said only 2% of breast cancers are due to environment. Well, okay, let's not study that, because that's only 2% of breast cancers. One of the problems with the analysis that Dahl and Pito did was they were thinking very much in a one disease, one cause kind of model. And I'll try to illustrate the problem with that. We know that smoking causes breast cancer. Causes lung cancer. We also know that asbestos can cause lung cancer. So in the Dahl and Pito analysis, if you had somebody who was a smoker who died of lung cancer, that was a checkbox in the tobacco, but not a checkbox in the environmental occupational box, because they only checked one box for each cancer. It's that kind of thinking that we think is out of date and is limiting what scientists are looking at. And so we worked with, or asked a team of scientists to go back and look at everything we know about breast cancer and revise that model and come up with a new model that better explains the complexity of breast cancer. And this is what they developed. So far so good. Looks pretty simple. It's just a circle. Has a few different colors here. The colors just indicate categories of factors. So physical, environmental factors, biological factors, behavioral factors, and social factors. And this is how we think they're all related. Much more complex than a one disease, one cause picture. So I'm showing you static pictures of this, but this is available on our website, and you can go in and click on things, and it's, if you have any part of geek in you like me, you'll have lots of fun playing with this. But I'll show you some examples of what it can show you. Actually, I forgot my qualifier here. You know, those pharmaceutical ads at the end, they always say, and side effects include. So, things you need to know about this, it's not perfect yet. And probably never will be perfect, but so right now it's only describing what we know about postmenopausal breast cancer. It includes some things that we think should be included. It doesn't include some other things that we think should be included. And it's a work in progress. And the same team is doing that work. So we hope the model will change in the future. And importantly, this model is only based on the evidence we've collected from human beings, which I'm sure you're all aware that a lot of medical research and discoveries are made using animals or using cells in petri dishes, and none of that work is included in this yet. And that's one of the things that they're working on now. Okay, now, let me show you some things you can do with this. So I here have selected race ethnicity as the thing I want to say. Oh, how is that related to breast cancer? So it is related to breast cancer directly, but it's also related to many of these other factors, with the arrows going in both directions. So, for instance, your country of origin has a big impact on what your race ethnicity is. But your race ethnicity also has a big impact on your endogenous hormone level, and also on your age at which you start your period. And so you start to see that you can't just say, well, how is this one factor related to breast cancer? Because there are many other factors that are also related to breast cancer, and they're all interrelated, and they all talk to each other and influence each other. One of the features I want to show you about this, if you do choose to play with it yourself, is you can click on a line, and it will tell you whether the evidence for that line is weak, moderate, or strong. And the thickness of lines also indicate how strong the association is. So does it quadruple your risk, or does it just increase your risk a little bit? And this up here is, there's two tabs up here you can select. One is the definition of the factor, and how it's divided, like is it a continuous variable, or are we talking about age of menarche before 12 and then after 12? And then the literature that gives you evidence for that association is also listed. So there is a lot of information in this innocent looking circle. And what we hope is that as it is more further developed, that communities can actually go in and enter in what their community looks like. What's the racial ethnic breakdown of their community? What's the age breakdown of their community? What is age of menarche in their community, etc. And look, and then determine from that where they can have the biggest impact in changing any of these risks, and therefore trying to change the experience of breast cancer in their community. We're not there yet, but that's where this tool is heading. And we hope it'll give some new evidence about ways in which we can start to prevent breast cancer from happening in the first place. And I will skip that example, and this is the web address for reaching that tool on our website. If you're interested in playing with it.